This is the result of a clinical trial comparing two chemotherapy regimens after surgery for colon cancer. And the two regimens are given here by the gold and blue lines. One is the control arm, 5-FU plus leucovorin, and the other is the experimental arm, which is 5-FU plus leucovorin plus the experimental drug, oxaliplatin. And what is being measured here is disease-free survival. In other words, the patient has had surgery and there is no evidence of disease following surgery, but of course there's a risk for recurrence. And so the patient may have a recurrence. So the question is, what is the proportion of patients who are disease-free after surgery? And the time axis shows data up to 4 years following surgery. Now, the first thing we notice is that the curves are very smooth, and in fact, it's a pretty large clinical trial. The number of patients enrolled in the study are shown here, 1,200 and 1,207 patients in each of the arms. You see a difference between the blue and the gold curves, and you want to know whether that's statistically significant. That's given here by the p-value of 0.0034. So what you need to know is, what is the p-value? Well, the p-value is this. The p-value equals the probability that this result would occur under the null hypothesis. Null hypothesis. What is that? The null hypothesis is the hypothesis that nothing is going on. So the p-value is 0.34%, that there's a 0.34% likelihood that what you see here would have occurred with oxaliplatin actually having added nothing to the 5-FU and leucovorin. So the p-value is pretty low, so it looks like this is highly statistically significant. The usual cutoff for clinical trials is that something is significant if it has a p-value of less than 0.05. 0.05 would be considered borderline, or 0.04. So being significantly less than that suggests that this is a good clinical trial. Now, what is the size of the benefit that's conferred by oxaliplatin? That's given by the hazard ratio. So the hazard ratio is a ratio of hazard rates for the two groups. Okay, what is the hazard here? The hazard here is the hazard that the disease would recur. And the way hazard ratio is defined is, the convention is the numerator is the experimental group and the denominator is the control group. And the hazard ratio uses all the data here, calculated by a very clever formula calculated by Cox proportional hazards. And what Cox proportional hazards does is it makes use for the fact that there is incomplete information in this trial. So another way of looking at hazard is, in addition to the Cox proportional hazards, you might want to explain to your patient, say, what are the chances that this treatment, oxaliplatin, which is not benign at all, there are significant side effects with oxaliplatin, most notably pain and tingling in the fingers and toes, which actually can become permanent in some cases. So what is the likelihood that you'll actually get benefit from the oxaliplatin in terms of preventing recurrence of the disease? And you could say to the patient, well, let's look at the 2-year mark. And at the 2-year mark, the chance that you would remain disease-free with just 5-FU and leucovorin, the chance that you would remain disease-free here would be 75%. However, what would be the chance that you would remain disease-free had you added the oxaliplatin? And that roughly here is about 80%. So by adding oxaliplatin, you've increased your chances of being disease-free from 75 to 80%. So there's a 5% benefit here. That means that if you take the oxaliplatin, there's a 5% improvement in your disease-free survival, but there's a 95% chance that you wouldn't have benefited at all. In fact, even without the oxaliplatin, there's a 75% chance you would remain disease-free. And even if you took the oxaliplatin, there's a 20% chance that the disease would come back anyway. So that's another way of looking at it. Now, moving on, let's look at a second curve. This is a randomized clinical trial comparing crizotinib against standard chemotherapy in patients with metastatic lung cancer. And what they're looking at here is progression-free survival. And they're measuring it over a period of months because the metastatic lung cancer has a pretty dismal prognosis. And what you can see for this clinical trial immediately is that it's a much smaller clinical trial. Far fewer patients are at risk. But the p-value is quite good, 0.001. And not only that, the hazard ratio is 0.49. Again, a very good number. What you can see is at the end, because this is a very small clinical trial, the curves are coming together, but we should ignore that part of the curve because actually the number of patients at risk is very small. Now, what is progression-free survival? Progression-free survival will measure the survival of the patient's still alive without progression of disease. So censoring here would occur for the various reasons that we discussed in part 1. Lost to follow-up, moved away, late entry into the study, or left the study due to toxicity. Now, the events are progression of tumor, so that each event causes the curve to drop. Progression of tumor, okay, that's progression-free survival, but also death, and death from any cause, death from cancer, death from toxicity of chemotherapy, or even death in a car crash. Now, this is progression-free survival, okay? So there's another thing that we talked about in part 1, overall survival. And overall survival simply uses as events death. It doesn't care about progression of tumor. It just measures death, with other reasons, obviously a whole list of reasons for censoring, which we had gone over. Now, there's yet another way of measuring things, and that's called time to progression. Time to progression is almost the same as progression-free survival, but not quite. And the reason it's not quite the same is in time to progression, one of the reasons for censoring in addition to all the other reasons is that deaths are censored. So deaths from toxicity are censored. Now, if the patient progresses and dies as a result of progression, that would count. But all other deaths are censored. So from the FDA's point of view, the FDA considers overall survival to be the best, progression-free survival to be next best, and of course progression-free survival matures more quickly because there are more events, and then time to progression as less desired than progression-free survival. So there you have it, a quick primer on how to read Kaplan Meier curves. Thank you very much.